Hi everyone. First of all, I'd like to thank the organizer, especially Dr. Sporia, for this kind invitation. It's a great pleasure to be part of this ultrasound workshop. Our topic today is cervical lymph nodes. As we know, the lymph nodes are superficial and superficial structures in the neck. When they are enlarged, they become palpable and should be difficult to distinguish between malignant and benign lymph nodes by physical examination. In this situation, ultrasound can help a lot. Just to understand lymph node in the lymph tract, here you can see and have a chance to reveal the anatomy and physiology of the lymph nodes. Take a look of this cortex and hilum. The only one place when we have blood flow in the hilum region and the central part of the lymph node. Note that in the cortex, there is no blood vessel. When you map with the color Doppler, it's important to take in mind this kind of physiology. And the other part is the lymph tracking. Also, in the different parts of the lymph node arrival through the superficial part of the lymph node. Concerning technique, the linear probe higher frequencies are appropriate to scanning cervical lymph nodes. When you have bigger mass, we can use convex probe with less frequency. As we know, ultrasound operate is dependent of our experience and depends on technique, interpretation, and knowledge of what we are scanning. When you have a high frequency probe and experienced operator, we can characterize more lymph nodes in the cervical region. Let's start by dimension. And on B mode, you can measure the lymph nodes, and the dimension is a poor criteria, in my opinion. Since we have 3 to 4 centimeter in diameter lymph node, very common and reactive in the neck region. Enlarged reactive lymph nodes are very common in this region. But if you need to have a cutoff of diameter, you can have 1 centimeter in transverse axis as a cutoff. The minimal diameter for any aspiration is 0.4 centimeter in diameter. Moving on shape, this is a better criterion comparing to dimension. Since we have, in most part of benign lymph nodes, fusiform lymph nodes, as you can see here in this clip. Malignant lymph nodes, more or less 86%, are rounded. And this criterion has 92% of sensitivity and 63% of specificity. It's interesting to remember that the normal lymph nodes in submental and submandibular region can be round as well. Here you can see some examples of rounds, and here as well. Round lymph nodes, malignant lymph nodes, and here is an exception of a malignant lymph node. It's fusiform, but you can see microcalcification as well. Regarding number, must be considered suspicious when we have 3 or more aligned lymph nodes in the same cervical level. When you have this higher than 1 centimeter in transverse axis, you can consider it suspicious. As you can see here, many of lymph nodes aligned. Here as well, like a conglomerate lymph node. Here's only one but enlarged lymph node, and this is normal, not abnormal. And here you can see easier scanning with convex probe to evaluate the relation with the vessel. The relation between hilum and the cortex could be this thin cortex and the higher hilum or enlarged hilum and hyperechoic hilum. The central and enlarged hilum are more showed in benign lymph node, and the narrow hilum could be part in benign and malignant lymph node, and that sense of hilum is predominant on malignant lymph nodes. The tumor cells is implanted in one part of the lymph node, differently from the inflammatory stimulus that this occurs in all parts of the lymph nodes. Then the relationship between hilum and cortex, determined eccentric cortical widening, is due to the tumoral cells. Is located just in one part of the lymph node. On the other hand, when you have this inflammatory stimulus, as I told previously, you can have a lymph node global enlargement. Here are some examples of normal lymph nodes here, the long axis and the transverse axis. And here an example of no hilum, or here narrow hilum and eccentric cortical widening and eccentric hilum here. Moving on echogenesis ecotexture, the normal lymph node is hypoechoic with cortex and central part is hyperechoic hilum. When you have a hypoechoic lymph node with distal enhancement, we can think about non-Hodgkin lymphoma. And if there is echogenicity higher and after chemotherapy, it's very common showed. When you have heterogeneous ecotexture, you need to think about the normal tissue with tumoral area inside. And here, heterogeneous lymph node with calcifications, here with necrosis, and here the echogenic lymph node due to microcalcifications inside. It's important to highlight that cystic lesions could be the first tumoral manifestation. It occurs in 50% of the cases. When you have metastasis, it's common to have thickened walls or internal echoes or nodule, wall nodule like here, or septum like here in this part as well. Only cystic metastasis could be appeared in 6% of the cases. And isolated cystic lesions could mimic benign diseases as branchial cyst. In this case, it's important to proceed to aspirate to dose the thyroglobulin level in these cases. The appearance could be cystic lesion, like here you can see. In this case, the same patient, you have the cystic lesion in the 4th level and the level 6 as well. And when you perform a fine needle aspiration, in case of cystic lesion, it's possible to send directly to dose thyroglobulin or calcitonin or parathormone. In this case, we have the diagnostic from the thyroglobulin dose. It was a papillary carcinoma metastasis, cystic metastasis. But if you have a solid lesion, we can wash out the needle into 1 or 2 millimeters of saline solution, and this is especially important to dose and to differentiate among many lesions without a representative cytology or when you have dots. As you can see here, the solid lymph nodes. Or to distinguish the thyroid bed nodules, for example, in this case, we map flow in these nodules in the bed thyroid. And we can see and dose parathormone or thyroglobulin or everything, or calcitonin as well. In this case, we have the same flow, the arterial flow, and the diagnosis was made by the needle washout, and the monocytochemical confirmed the nature was parathyroid and not metastasis of thyroid cancer in the thyroid gland bed. Another example here in the level 2, elongated nodule with a color Doppler mapping as abnormal lymph node or another thing we didn't know at the phase. We performed fine needle aspiration with dosage of parathormone and thyroglobulin, and it was positive for parathormone. And the MIB confirmed this parathyroid nature as well. Concerning necrosis, the pattern could be divided in two types. A necrotic area, as you can see in these cases here. A necrotic area means liquefaction, cystic necrosis, could be in malignancy, as non-Hodgkin's lymphoma, squamous cell carcinoma, papillary carcinoma, or tuberculosis as benign disease. Or hyperechoic hemorrhagia, hyperechoic area, hemorrhagica, or lesogenic then hilon coagulation necrosis. It appears in general in squamous cell carcinoma, as you can see here, one good example of this, and here as well. Considering calcifications, microcalcifications must be faced as a warning. Here you can see some examples of microcalcifications, and then another example of a small lymph node with the microcalcifications inside. We call it attention. And here we can have coarse and microcalcification as well. And here microcalcification in necrotic area. Another example of peripheral calcification is benign calcification in this example. And here a pattern of snow storming and microcalcification, a lot of microcalcification made in this pattern. Moving on, extracapsular spread, the signs of dissemination of vascular invasions are loss of limits, as you can see here, spiked or bosselar edges, involvement vessel more or equal to 180 degrees, loss hyperechoic vessel band, reduced tortuous of vascular lumen, and absence vessel or tumor mobility. It's important to have attention to cross-section. It's very important to evaluate the relation with the vessels. This is my clue for you. Take in mind that the internal jugular vein is the most affected vessel, and when we have carotid invasion, could be limited for surgical conduct. Here an example of involving jugular vein here, making a stop in the vein, the long axis and the cross section here. We can see making this, and you can see the loss hyperechoic vessel band in this example as well. Here you can see the jugular vein and the carotid. And in another example, this case we have involved carotid bulb incarcerating vessel more than 108 degrees involving this vessel. And the same case you can see in the cross section, the carotid, the bulb with the normal hyperechoic vessel band, and here the loss of hyperechoic vessel band. Then it is very, very useful to have this cross-section when you made this analysis. Another help to distinguish if the mass is invasive or stuck to the structures of the vessel is its mobility, which can be seen with the forced cough, or swallowing water in the real-time ultrasound. As you can see here, the water swallowing from through the esophagus, and this mass is not stuck to the esophagus structures. One clue: if you scanning by pulsed Doppler one thrombus and detect arterial spectrum inside the vein, we are authorized to call malignant thrombus inside the vein, not a blunt thrombus, as you can see here in this example. The color Doppler is useful too and can be performed easily and speed. In order to obtain the best performance, it's important to observe the controls and not to compress the skin when you are performing color Doppler. Pay attention of wall filter, speed scale, Doppler gain, and filter level. Here, the example of normal lymph node, as I told previously in the first slide of this presentation, is important to observe the blood vessels are normally located in the halo and the central part of the lymph node. Here's some example of normal scanning of normal lymph node with color Doppler, the hilum, and the color Doppler in the central part, and the hilum part of the hilum region of this lymph node. Other normal vascular pattern are when we don't have any vascularization or Hiller pattern. And here, when you have elongated and a hypercortical lymph node without central hypercortical hilum, you can proceed to the mapping on color Doppler and see the central region with the vascular structures. Color Doppler can help also to identify halo, as I showed you. In this case, the same, round lymph node, no evident halo, but after color Doppler, you can observe the central region of this lymph node with the blood vessel. Summarizing the normal pattern, we can find also hilar vessel, longitudinal vessel, and branches, and central short vessels. On the other hand, when you have abnormal lymph nodes, we can see some patterns as capsular or peripheral vascularization, as you can see here, chaotic vascularization, speckled or some avascular region, it means tumoral embolus, or radial type, or mixed pattern. This could be displacement vessel or curved course of internodal vessel, aberrant vessels, avascular pole, as you can see here, or subcapsular vessels. This alterated vascularization has sensitivity of 91% and specificity of 8%. Some examples of abnormal lymph nodes with vascularization, displaced and curved vessel inside the lymph node, this chaotic lymph node, the mixed pattern, and a vascular pole, and mixed part as well, and this aberrant vascular part of the lymph node. Another examples of necrotic area, and here necrotic area, but we can see vascularization in the septum, and here tuberculosis, another example of the septum with the vascularization, and here papillary carcinoma as well. Another possibility is to perform a pulsed Doppler. From the spectral analysis, we can calculate resistive indexes. Benign inflammatory disease, you can have lower indexes, exception for papillary carcinoma. Intermediate indexes you can see in lymphomas, higher indexes in metastases, as you can see here. The best cutoff for RI is 0.77, but this RI is controversial. It's important to note that papillary carcinoma can present lower, intermediate, lower, and high indexes, resistive indexes. And here an example of a medullary carcinoma. And we need this question. Is it profitable to perform a pulsed Doppler for lymph nodes? Since the time to perform a pulsed Doppler adds 10 minutes to scan lymph nodes and color Doppler only 2 minutes, it's not fruitful performing pulsed Doppler always. In my practice, I use this tool only to distinguish the nature of lesion overall in the thyroid bed nodules. In summary, lymph nodes have been pattern of benignity as morphology elliptical, fusiform, homogeneous, helocentral, narrowed cortex, regular margins, and vascularization, the hilar, little irregular vessels with lower indexes, resistive indexes. Otherwise, malignant lymph nodes are globular, round, or conglomerates, heterogeneous with liquefations, microcalcifications, eccentric thin or absence of hilum, enlarged cortex, and mostly irregular or poor defined margins. And the vascularization, subcapsular disorganized tortuous branch with higher resistive indexes. What is a suspicious lymph node or suspected lymph node? When you have not relevant for dimension or number of lymph node, but for shape when it's round or altered echogenesis, like you can see here with microcalcification, extracapsular spread, like poor defined control or suspicious vascularization, microcalcifications, and unusual pattern of vascularization. The ultrasound sensitivity and specificity are high and can be used for distinguish benign from malignant lymph node with high sensitivity and specificity, and a very good screening method with sensitivity higher than 80%. And could be used for distinguish benign from malignant lymph nodes. And another possibility to help our surgeons is to mark with the charcoal the metastasis. This is particularly interesting if you have papillary carcinoma metastasis to undergo reoperation. As you can see here, in a young woman with the needle, you can mark with this charcoal, activated charcoal, and avoids neck dissection, as you can see from this surgeon with this mark. In conclusion, ultrasound routine to track tumor recurrence is one of the most important tools recognized as abnormal lymph node patterns. Examination must be through parotid gland to cervical inferior region. It means cervical examination method. We needed to have this. Color Doppler lesion suspected lymph node increases our specificity, and pulsed Doppler only in some cases. In case of to know the nature of vessel research, example is thyroid bed examination, and ultrasound can guide fine needle aspiration, cytology, and washout needle. It's very, very important tool for us. And ultrasound can mark metastasis for reoperation with activated charcoal. Thank you for your kind attention and virtual participation.